Bob Myers. I'm president of the National Press Foundation. We are an independent, nonprofit organization devoted only to professional development programs for journalists and awards for accomplishment. We are not affiliated with any other organization. We're delighted this morning to be co-sponsoring this event with WGBH in conjunction with the important public television presentation on November 1st, 2nd, and 3rd of RX for Survival, a Global Health Challenge. Public health is the health across populations, and it may be, for journalists, one of the most important topics imaginable. In our modern world, events take place around the globe, and they can affect us immediately here at home. Some of these events are unpredictable, such as an earthquake or a hurricane. Others are chronic, like malaria or waterborne diseases. All of them can be anticipated, responded to, and described by journalists. We play an critically important role in informing individuals, governments, and societies of what is happening elsewhere, what can be done to prepare, and how the response is going, or not going, or should be going. Let me take this opportunity to welcome my colleague, Nanda Chitri, and offer her the opportunity to greet you as well. Nanda?
Good morning and welcome. I'm Nanda Chitri. I'm here on behalf of RX for Survival, a Global Health Challenge. This ambitious multimedia project is being co-produced by the WGBH Nova Science Unit and Vulcan Productions, with major funding provided by the Bill and Melinda Gates Foundation and the Merck Company Foundation. The narrative heart of this project is a 6-part PBS series that will air November 1st through 3rd that combines up-to-the-minute documentary stories with brief historical dramatic recreations to help viewers understand the critical issues and breakthrough moments in global public health. And you'll be seeing some of the highlights from the series later on this morning. RX for Survival is also a major awareness initiative with many partners ranging from media, health, and humanitarian organizations to civic and educational groups. We are very grateful today to Bob Myers and the National Press Foundation, and especially to all of you for participating in this conference. In today's global society, the health of every human being can affect each of us. An outbreak of infectious diseases is no more than a plane ride away, and even those sitting in first class are at risk. But before many of the natural disasters of this year, global health was a subject that did not appear very often on the media landscape. Yet a 2004 national survey that we commissioned found that 53% of Americans had some concept of global health. And perhaps most importantly, our research showed that by nearly 2-to-1, Americans reject the idea that the world's health problems are too big to solve. So, knowing this, we as journalists, filmmakers, educators, and web producers asked ourselves, how can we not cover this story with the depth as well as the immediacy that it deserves? But we wanted to do much more than have a PBS series on global health. First, we wanted to be able to provide a high-end forum for a select group of journalists to discuss the opportunities and obstacles of global health reporting. An earthquake in Asia takes 50,000 lives. That's news, while the everyday deaths of 30,000 children is not news. It's, quote, the wallpaper, unquote, as New York Times columnist Nicholas Kristof recently said. But disasters or even potential pandemics like Avian Flu can put the spotlight on the need for global public health preparedness and signal the need for change. Second, we also found that the producers had amassed thousands of facts and hundreds of personal stories. And rather than let all of this knowledge sit in shelves and filed cabinets and buried in emails and hard drives, we decided to commission a newsroom guide on global health to share with you, our colleagues in journalism. We're very pleased to offer you the first of these guides that are just delivered from the printer, and I think most of you picked them up outside. Only an informed public can be expected to act responsibly. And we believe that by taking a more proactive journalistic stance, understanding that fresh and compelling stories are there if we make the commitment to find them, I hope today is the beginning of an even broader effort to improve global health coverage in the United States. Thank you again for all participating in this conference.
Thank you, Nanda. We're going to have three panels today, and we'll be hearing from some of the world's leading experts on our subjects. The first panel will look at avian flu and other potential pandemics. The second will look at global health crises and child survival. We'll have the brief preview of RX for survival that Nanda mentioned. Then we will hear from a panel of journalists who have reported on global health crises around the world and here at home. National Press Foundation programs are always on the record and include plenty of time for questions and answers. So the people sitting there are going to work just as hard as the people sitting here. There is in your packet an evaluation form in this attractive yellow format. Please fill it out. It is very important for us to know how this format and this kind of program work for the purpose of educating journalists. There's coffee in the back. Lunch is going to be available. Our first, I mentioned the evaluation form. Our first panel is on avian flu and tomorrow's pandemics. Dr. Michael Osterholm is Director of the Center for Infectious Disease Research and Policy, Associate Director of the Department of Homeland Security's National Center for Food Protection and Defense, and Professor in the School of Public Health at the University of Minnesota. He is also a member of the Institute of Medicine of the National Academy of Sciences. Dr. Rex Archer is Director of Health for the City of Kansas City, Missouri, and President of the National Association of County and City Health Officials. Dr. Olusoji Adeyi is Coordinator of Public Health Programs at the World Bank and an Adjunct Professor at the Johns Hopkins Bloomberg School of Public Health. Each of them will speak for 5 or 10 minutes, and then we will go to Q&A. I've offered the speakers the opportunity to either speak here from the podium or from their seats as they choose, and we look forward to their remarks. Dr. Osterholm?
Good morning. Thank you, Bob. I will speak from here so I don't ignore this part of the audience over here that we can't see from the table. First of all, I'd like to congratulate and really acknowledge the incredible effort that's been put forward to make this all happen. Having had the good fortune of being involved with some of the planning around this, which was almost, I believe, 18 months ago, there has been a tremendous concerted effort to really lay out the issue of global health as unlike I've ever seen it done before in this type of format, and I think it will serve as a primer for all public health, government officials, and the media as we go forward in terms of some of the issues before us. Now, today I have the dubious distinction or terrible challenge of trying to lay the context for global health as we sit here potentially on the cliff of a pandemic of avian influenza, or that term avian influenza, which has now been coined in the popular press. This is a significant challenge because, quite honestly, in my 30 years of public health, having been involved with many different issues emerging from such things as toxic shock syndrome, HIV/AIDS, emerging infections worldwide, antibiotic resistance, terrorism, etc., I was often asked in my career, how did I sleep at night? And to my embarrassment, I had to say, well, I'm sorry, but I do. In fact, my family would suggest I have fallen asleep in the middle of giving directions. I lay awake at night thinking about pandemic influenza. It scares the hell out of me. And so I don't want it to overshadow all the issues today because there are many very important global health issues that are not related to pandemic influenza. But you cannot ignore the gigantic dinosaur in our kitchen today. It is there, and it truly is an overwhelming thought. Let me make just a couple of points about pandemic influenza. First of all, it is a lesson in public policy. In 1861, if Congress had marched down from the hill up here and gone down to the White House and said to President Lincoln, you know, the Civil War stuff's just not something we really want to take part in. Rather, we would really like to take the entire federal budget and get to the moon by the end of the 1860s, they could have done that and they would have never gotten to the moon. The technology was not there to do it. Rather, in 1961, when a then newly elected president decided we're going to get to the moon by the end of the decade, but it's going to take an incredible effort, it was done because the technology was there. Today we have within our midst the technology to handle many of the issues that we're going to talk about here today. but we've never made the commitment as a world. We've never understood how to put that in the context of global health. And so today, one of the challenges we have is not just talking about the problem, but talking about what we're going to do to solve it, and talking about missed opportunities. I will tell you right now, for some of us who've been on the pandemic influenza bandwagon for decades, not weeks or months, we would have had the opportunity, following our scare in 1976, to have put together the technology, to have put together the commitment to not be where we're at today. We could have a global vaccine supply that would be available with new modern vaccines, unlike the slide ruler type vaccine. And for the 2 or 3 of you in the room old enough to remember using slide rules in the 1950s, remember, with one slight exception, that's the same vaccine technology we're using today to make influenza vaccine. We also understand commitment. As Andy Granatelli, the famous STP race car driver commercial, used to say, you can pay me now or you'll pay me later. And for many of these problems, we understand what it's like to pay later. Look no further than New Orleans. So today we're also here to talk about that. If in fact we had committed 20 years ago or 30 years ago to this influenza situation, as I said, we wouldn't be here today. The other issue I would raise with you is, why is global health important? If in fact we could, and we can't, and I'll just say in a moment a brief comment about that, if we could find a vaccine that could be readily available to U.S. citizens shortly after or coincident with the onset of the new influenza pandemic, and we could protect all of us, the collateral damage to this country would be unimaginable anyway. Because we live in a global just-in-time economy today that depends on both the developed and developing worlds. Do you know where most of your pharmaceutical products that are not related to influenza come from today? Do you know how thin those supply chains are? Do you know that we would lose many of the pharmaceutical products in this country because, in fact, those supply chains would collapse? Do you know where your food supply comes from today? Do you realize when global transportation shuts down, we would lose much of our food supply, both domestically, as it's grown here and moved, or as it is brought in from foreign countries? I could go through a long list of essential products and services that will collapse with the collapse of the global economy associated with the pandemic because of what I believe will be an inevitable closing of borders. And that's even if we were fully protected. So the idea of a global health today is not just a term. It's not just altruism. It's not just the fact that we want to be good citizens. It's about being smart. It's about being strategic. And I fear that we don't still get it. Now let me just say a couple of words about pandemic influenza and I'll close. First of all, contrary to what you read in the media, and right now I fear we have a media on steroids. You have to go from crisis to crisis. And in fact, everyone's wondering, where did this flu issue come from? Why is it suddenly a major issue when, in fact, yes, post-Katrina led us to understand that we are not nearly as prepared as we thought we were. Yes, there are some new publications that came out that gave us even more reason to believe that a 1918-like scenario could be replayed. And yes, the President, after hearing in a number of briefings from his people at the Department of Health and Human Services, this is a serious issue, they all came together. But folks, none of this is new. None of this is anything that wasn't already there. And as I said yesterday in a commentary that was written in the St. Petersburg Times, I worry desperately that if a pandemic of influenza doesn't occur in 6 to 8 weeks, maybe as long as a couple of months, which, guys, I hope it doesn't happen that soon, there will be tremendous blowback because they'll say, you scared us needlessly. Why did you say this to us? Knowing full well that there will be a pandemic of influenza. I wrote a book that was published on 9/11 of 2000, 1 year to the day before 9/11, called Living Terrors. In that book I talked about the Al-Qaeda and the World Trade Center towers and the whole risk of terrorism. If you had asked me in that intervening year between 9/11 of 2000 and 9/11 of 2001, what's the chances the World Trade Center would have an attack like that, I would have probably told you 1 in 10,000, I don't know, but enough that you really have to take it seriously. I will tell you today unequivocally the risk of another pandemic of influenza is a 1. It's a 1. There have been 10 pandemics in the last 300 years. Influenza virus, which evolves out of wild birds, ultimately goes through genetic changes periodically and then gets into the human population and causes a variety of different types of pandemics, those as severe as 1918 and 1830, going 15, 30, and those are milder, like the 1957 and 68 pandemics. They occur. Unless someone today can stand here at this podium and say we now have a means to stop tsunamis, earthquakes, and hurricanes, they cannot say we won't have another pandemic. The question is, when will it occur, where will it start, and how bad will it be? And many of us today are convinced that the culmination of events in Asia with H5N1 and what's happening there is everything about the next pandemic. And in the question and answer, we can cover that. And so today, we have a number of critical issues before us. You'll hear about any number of global health problems. If I've left you with nothing else today, know that it's not always about the fact that we couldn't solve them, it's that we don't solve them. Second of all, global health is really critical to every little coffee shop, every gas station, every church, every school, every business, every hospital in this country. It's not just a function of something on the other side of a border. And finally, we're in for some tough times ahead. We will, I believe, rewrite our American history with pandemic influenza. Those are strong words to say, and I wouldn't say them if I didn't honestly believe them. And today, this format hopefully allows us to get a sense for just what that means and to understand what your role as the media will be in responsible reporting. I would conclude with my motto has been and continues to be, and I hope that it is something that the media can embrace, it's our job to scare people into their wits, not out of their wits. And today, I hope that's what we're able to accomplish. Thank you very much.
Dr. Archer.
Good morning. A tough act to follow, but it is a sobering act. If I was to start off by asking you a question, how many of you believe that we have the best illness care system in the world? There might be a few hands that would go up. But then if I asked you how many of you believe that we have the longest longevity of any nation in the world, I would hope no hands would go up, because we don't. We're not in the top 5, we're not in the top 10, we're not in the top 15, we're not in the top 20. We'll bounce around from year to year on the estimates down around 25th in the world. Part of that is because our belief in the cure gets in the way of improving the quality of our life and living longer. And so much of the focus and misdirection and expectations that have been going on have to do with the concept that we can cure anything and that we don't need to bother to prevent it anymore. So I want to focus a little bit about, though, why I believe we're here today talking about this issue. As Dr. Osterholm said, after Katrina, it made us aware again, or I think we have an opportunity to relearn something that we've known, which is that pre-deployment is critical. That you don't save lives in a disaster by waiting until the disaster is there and then try to respond. So what is pre-deployment in regards to a communicable disease outbreak, something like pandemic influenza? Well, one of the important things obviously has to do with isolation and quarantine. We don't do a very good job in this country with infection control in our hospitals. Excellent article a few years back, the Chicago Tribune kind of pointed this out to everybody, that we're losing more people every month that go into a hospital, get an infectious disease they didn't have when they went into the hospital and die from that than died in the Trade Center on 9/11. So if we don't tighten up those kinds of things in this country, we're not going to be doing very well. If you look at the challenge of SARS, SARS was not very communicable. It basically took poor infection control in hospitals for it to spread. Pandemic influenza is likely to be many times more communicable. Let's talk a little bit about quarantine, because that's been raised recently. In a sense, what I'd like for you to think about is that just as when somebody is selected for jury duty, or if somebody has to go overseas with a commitment because they're in the reserves or military. Their job is protected while they're doing that service for the country or for the local community. We need protection for people that are put into quarantine. We need protection for people who don't have sick leave and are living paycheck to paycheck. We have problems right now in this country with outbreaks, particularly foodborne related issues with food workers, where we don't get reported to us as quickly or as often as we should because people are scared. They're scared that they may lose their job. There's not protection there right now. Daycare outbreaks are another good example. If there's a child that's sick in a daycare and they have an infectious disease and we keep them out of that daycare for a period of time until they're well to come back, what does the parent do that has to stay home with them but doesn't have sick leave? Sometimes they take them to another daycare. So we need to look at this realistically. Second issue that was already mentioned is vaccine production capabilities. It's a little late to be building the plants after it's here. It takes a significant amount of time. One of the things that we believe as a national organization, our National Association of County and City Health Officials, is that if we set the goal for annual universal influenza vaccination for the entire population in this country and start doing everything we have to do to get there, just as was mentioned in getting to the moon, if we lay out all the things that need to be done to get the entire population to get a flu shot every year, or as close as we believe we can get to that if we try to set a goal, say 90%, a lot of benefits from that. One will be it'll help to stabilize the demand for vaccine. Two, if I was to stand here and say we're going to be on the moon in a few years again, and we had never been there before, we had never put an astronaut into space at all, I might get questioned a little differently than if we had already done it. This is the same issue here. If we can't vaccinate 90% of our population in a few weeks each year, how are we going to do 99% when they want it, particularly if they may end up needing more than one shot even because it's a new enough organism that they need a booster. And the last issue that I want to focus on has to do with trust and relationships in communities and how people go about their business, how they take the information they get from the media and then what they get from their social groups within their communities and how that all sorts out and leads them in the right way or the wrong way under various kinds of challenges or panic situations. If we look at the tale of two cities, and some of you may have heard about this before, when there was a smallpox outbreak in New York City in 1949, I want to compare that to a smallpox outbreak that occurred in Milwaukee in 1894. In Milwaukee, when that outbreak occurred, the authorities were very draconian. They really came in hard, gangbusters. They did not have the relationships with their local communities. They didn't understand the diversity. They were not trusted. And they had riots over that situation. The outbreak went on needlessly long. Several hundred people died. In New York City in 1949, if you can imagine, people lined up for miles and didn't cut in line to get their shot. You can see pictures of this, people out in the streets in lines. And that was accomplished because the public health department was strong, had great relationships with its community, went through a process of making sure that at the grassroots level, at the same time that the media were reporting issues, that they were reinforcing the messages. Technology can go a long ways towards solving problems, but it doesn't do it without also people that have relationships and are trusted. If you're in a community and you have an 18-year-old National Guardsman that's never had a course in biology or infectious diseases standing down at the corner with a gun, are you going to trust that person more than a public health nurse that you've seen working in your community day in, day out on other health-related issues and when they give you advice? We cannot, it'd be like having a military and just deciding to have planes or aircraft carriers but not having anybody to run them. That's the state of affairs we're in this country right now. Thank you.
Dr. Olusoji Adeyi.
Thanks. Good morning, everyone, and well, thanks for having me. It's a tough act to follow Dr. Osterholm and Dr. Archer, so I would like to take off from where they left off and to talk about just 3 items. The first is, what makes this global? The second is this uniquely bad, and is there any benefit to be had from it? And the third is, so what can be done? Well, what makes it global is that in this day and age, there is no such thing as the protection of a vast ocean anymore. Dr. Osterholm has told us that the risk of a pandemic of avian influenza is 1. So it's a question of when, not a matter of if. Now, in that scenario, even if one country were able to hunker down, even if one country were able to immunize all its residents effectively, what about the knock-on effect of a potential global economic meltdown? Well, your kids may not have imports from China of all those fancy Halloween costumes they want to wear, and there are many other things that may not happen. That is how it becomes localized. Schools may close down. Health workers in hospitals may be among the first to be affected, and it's a complete shutdown. Now, those who have a night from history may recall when Winston Churchill was defeated after the World War, and he wasn't very happy. I don't know many people who like losing elections, and I recall there was heard to grumble that this is really bad, and Mrs. Churchill said, well, this may be a blessing in disguise, at which point Winston, ever quick on his feet, said, if it's a blessing, then it's very well disguised indeed. So maybe this is a blessing that is disguised in a very, very terrible mask. What does it all mean? Let me take you outside this room, because while a pandemic of avian influenza will be a uniquely bad, or could be a uniquely bad event in world history, there's actually a lot of bad stuff going on out there as we speak. It just happens that those who live in wealthier societies are removed from the day-to-day realities of millions, and in fact hundreds of millions of people in poor countries, be they middle-income countries, be they low-income countries. And as a result, there's a certain degree of insularity that has developed. If we look at some of the data we have from the World Health Organization, and I'm not revealing to you a secret here, it's all in the public. Every year, countries lose millions of children to readily preventable or readily treatable diseases. Respiratory infections are still there. Tetanus is still there. Some of this may sound very strange to those of us who live in the comfort of very rich societies, but they're realities, daily realities for a number of people around the world. AIDS killed close to 3 million people in 2003, and malaria still kills some 1 million children in Africa every year. These are daily realities for many people out there. So what is the unifying factor in all of this? There are some things that the market will not take care of. There are some things that individual responsibility will not take care of. There are profound market failures, and there are profound policy failures. And we delude ourselves if we think that because some societies are able to take care of these scourges that are referred to, that then we're protected. We're not. There continue to be failures in public policy all over the world. And there continue to be market failures all over the world such that people cannot get access to basic vaccines, for example. They cannot get access to basic medicines, for example. What are some of these functions of the state? Setting policies for those things that individuals cannot reasonably be expected to take care of. Ensuring that epidemiologic surveillance gets done, that there are trained workers, that they have the equipment required to do their work, and that there are roads, that communication facilities actually work so that they can be reported. Because without an effective surveillance system in public health, it's like an army fighting without any command and control facilities whatsoever. This also relates to the never-ending debate about the effectiveness or ineffectiveness of foreign aid. Well, it actually does work. It depends on the context. It depends on where. For those of us who are members of the press, I recommend to you the publication entitled Millions Saved, published by the Center for Global Development. It contains a number of success stories, large-scale successes in international health. Success is actually possible. It is not a story of doom and gloom. So what does this mean for the future? There is a need for transformational leadership. A compelling vision. But vision is not enough. I remember from my days in clinical practice that even psychiatric patients had vision, so vision alone is not enough. So a compelling vision and a commitment for the long haul. This is going to be a marathon. Improving global health and the infrastructure for public health is a marathon. It does not take the mindset of a sprinter. It means putting up the money on a sustained basis so that these problems can be taken care of, so that the infrastructure for maintaining successes can be taken care of. I continue to remember this very articulate, very eloquent person I met in, this was in Mozambique about a year ago, and over a cup of coffee he said, I'm really frustrated at the way a number of people agonize that success will not be sustainable, when in fact they're only too happy by default to sustain a pattern of underperformance and a pattern of failures. Thank you.
All of our programs have time for Q&A, so and we have a microphone in the audience, so please raise your hand, and Phil Donahue will come and you'll be able to answer questions.
Hello. I think this would be primarily for Dr. Osterholm, but perhaps others would know as well. You've been speaking about, there's really two related questions. You've been speaking about the fact that there's been 10 flu pandemics over time. Number one, what do we know about the relative risk that this will be a severe epidemic, if and when it occurs, versus a not so severe epidemic like the 1968 or 1957 flu? Certainly the last two have been not so severe. And what's the basis for the rather precise-sounding estimate that's floating everywhere that the next time there's an avian flu, 500,000 Americans will die and 2 million will be hospitalized? How can we be so precise about that? And what's the basis for that?
Thank you for that question, because I think it's a good framework question to begin that whole discussion on avian influenza. First of all, let me just make it really, really clear that I know less about influenza today than I did 10 years ago. I knew much more about it because, in a sense, there has been a lot of dogma that's arisen around many of these infectious diseases. I was recently asked to do a review for the New England Journal of Medicine on our preparedness for pandemic influenza last spring. And I went back to the primary textbook of infectious diseases where there was a very wonderful chapter on influenza, and I called the author and I said, now, where did you come up with this number of how many pandemics there have been over a certain period of time? He said, well, the previous author that wrote the chapter had that in there, so I just kept it. So I called the previous author. He says, well, I think I got it from this guy. So I called this guy and he says, I don't know, I just kind of remember that number. And I kept tracing it back. No one knew. So John Barry, the historian who wrote the very wonderfully descriptive and painful to read book on the 1918 pandemic, which I would urge you all to read, and I have been looking at this, and that's where I came up with the number. In fact, if you look back, there is a lot of wives' tales, you might say, in this whole business of influenza. So, in fact, that's where the number came up. Is I literally went back using historic records and other textbooks to come up with the number, which is different, by the way, than in the textbook. And what I've come to realize is that we didn't know a lot about influenza. Up until a year ago, I would have this debate with one of the premier influenzologists of the world, whose opinion has often been taken as gold, where he adamantly said that every influenza pandemic occurs when a phenomenon known as reassortment occurs. Reassortment is the process where the influenza virus coming from wild birds, and that is the reservoir for influenza viruses. The term avian influenza is really a bad term because there are many avian influenzas. I mean, there are ones we deal with in the poultry industry every day, H7, H9s, other H's that are not H5N1. So the veterinary world gets real confused when we call this the avian influenza because they have many. But in terms of looking at this issue, what has happened in the past is this virus comes out of that wild bird world, and typically we thought it went through domestic animals, pigs. Pigs actually have the unique ability to be infected by both the bird strains and human strains. Human strains ultimately occur when that wild bird strain either it changes enough genetically so now that it has a lock and key to get into the human lung cell. The wild bird virus just does not infect humans well at all. And it was used to be thought that reassortment was the only way to do that. And reassortment occurs when a wild bird virus and a human virus get into the same lung cell. We thought in pigs. And because this virus is so promiscuous, it's so indiscreet, and it's so sloppy, that it'll exchange its genetic material readily with other influenza viruses, and while a third virus comes out, which is the 57 and 68 experiences we know for a fact. Prior to that, we didn't have virology. Well, he was insistent that that's the only way a pandemic could begin, and yet the 1918 data didn't support that. As you know, 2 weeks ago, some very important papers were published in Science and Nature, in which the 1918 virus has now been reconstructed totally de novo from just identifying the 8 genes of the influenza virus from samples from dead people, not growing the virus, but literally reading the genetic material off of that and then turning around and recreating the virus. So we now have a 1918 virus. And with that, we were able to do additional studies, and it's been confirmed beyond a shadow of a doubt now that the 1918 virus actually emerged directly from birds to humans. It didn't have this reassortment. It's what we call recombination, cumulative mutations that occurred. And that's a very important point because, in fact, that's what's happening right now with H5N1. We have no evidence of reassortment in the years that it's been circulating, but what's happened is we live in a world today where there are so many animals in Asia. Asia will remain the genetic roulette table for influenza virus. I have no doubt about it. So even though there are these invasions in Europe and in Eurasia in general, the primary focus is Asia. Look at China. In 1969, the last year we had a pandemic, in China there was about 5 million chickens. Today there are 13 billion chickens in China because of the change in social, cultural, political, and ownership issues. And those chickens are harvested every 18 weeks. So in essence, it's really 3 cycles a year, i.e. almost 45 billion birds are turning over every year in China. That's the kind of place in Asia in general where we're going to see this. The question you ask is, well, what will this be like? Well, the 57 and the 68 outbreaks were clearly reassortments, where a bird virus, a human virus got together, and I think that we now recognize, and I can't support this and say it's absolutely true, and I'll make clear to everyone else, those were reassortments, and I think it dumbed down the virus. So those were milder pandemics. The 1918 virus has all the makings today of being reproduced in the H5N1. In 1918, and for those of you who want to get the right numbers because there are many numbers floating in the media right now, there was a very well-done study by a group of historians several years ago, published in the Journal of the Bulletin of Medical History, and it's the first reference in my New England Journal paper, actually went back country by country by country and looked at the mortality to the 1918-19 pandemic, and their estimate is at least 50 million died and more likely 100 million. That, I think, is today the best estimate we have for 1918. And all the numbers you're getting here that you ask about are really just an extrapolation of either the 57, 68 outbreaks or the 1918. The CDC model, which you recited earlier, basically is, in terms of the numbers of deaths in the United States, is the 68 pandemic, which was a very mild one. Today, we think up to 1 million people a year die from flu anyway, regular flu. So when the WHO says it could be as bad as 2 million, I hate to say, 2 million lives are still 2 million lives, but that's almost a yawner when you think of what it's doing already. I mean, I don't know if any of you would even write a story about it. On the other hand, if you extrapolate the 1918 experience to today, that's 180 to 360 million deaths worldwide, based on the 1918 population, which was 1.75 billion. Today it's 6.5 billion. And you can say, well, but we have modern medical sciences. We can spend time going into that. We don't have any better way to handle the kind of illness that this virus causes, the cytokine storm phenomena, where it's your own immune system that does you in. In a 3-month period in Boston in 1918, which was duplicated in many locations around the world, 5.7% of all the people between 20 to 40 years of age died. That's a remarkable situation which we believe could occur today. So to give you the numbers in this country, and I believe I will foreshadow the HHS preparedness plan, which will be coming out soon, says that we have to prepare up to 1.9 million deaths in this country for a 12 to 24-month period associated with flu. And I think that is a very fair upper bound of what we might see with the pandemic of influenza.
Other questions and comments?
Soji referred to the success stories in Millions Saved, which is very happy-making reading compared to what we're hearing now about a possible pandemic. But most of those stories, I think Soji would agree, are about long slogs to get to success, about taking quite a few years, getting polio almost eradicated, eradicating smallpox, bringing guinea worm under control. None of these successes happened against something that could overwhelm the world in the space of a few weeks or months. And I think that the comparison just reinforces what Dr. Osterholm was saying about if you need a long slog to be ready, you need to start it probably 10 years or more before the storm actually hits. We've done this in some ways with knowing what might happen. We don't seem to have done it with actually preparing for when it happens. And the hurricanes to which you referred are a nice example. We can now track hurricanes extremely well. That doesn't mean that people get out of the way in time, and it certainly doesn't mean that we're protected against all the damage they can do. Is there any way that the three of you can think of to speed up that process, or are we condemned to a long slog that will start after the next wreckage?
Certainly, the ability to shape public opinion and get the word out that something can be done can help that process. I would argue that the 30, 36, 40, again, you can get different estimates each year on how many people are dying in this country from our annual influenza experience, that we could put many things in place that would save many lives there that would also prepare us better for a pandemic situation. As I said, if we look at our vaccine production capabilities and look at our distribution systems in this country that need significant work, we could make significant strides. We need to re-educate our population on hand washing. It's amazing how few people still wash their hands in even half of the appropriate situations or settings that they need to be doing that in, and we need to get back to some of those basics. In a sense, from a preparedness standpoint, I would say that we are at the best level of preparedness in a few areas. But there are many areas where I think we are actually losing some ground. And overall, over the last 5 years, I think that we've been making some progress, but not at the rate that the risk is going up. It's a little bit like if you're in the airport and you've got to get to your next connection, and you start moving to the next connection and it's really tied up, and you see an empty walkway, and it's empty because it's turned off, but you think, well, I can go down that walkway. So you're moving down that walkway rapidly, and then the walkway starts up, but it's moving towards you. And you're having to now work even harder to try to make progress. And if you're not moving faster than the walkway's moving towards you, you're not going to make progress, and you may not get to your gate. I think that the risk of, when you look at all the new zoonotic diseases that are hitting, when you look at the population rates, the animals, the risk of zoonotic diseases, we are not beefing up our, for lack of a better way of saying it, our interstate highway defense system, but calling it an interstate infectious disease defense system, which is what we really need to be doing. When Eisenhower came back after World War II, said we need to build an interstate highway system. We need to be able to move troops around in case we're ever attacked. Now, there are a lot of other benefits that have been created from that highway system, but if we waited until our soil was attacked to then decide to build the interstate highway system, we wouldn't get it done in time. So it's that kind of an issue that I think we need to look at. Where can we get double wins? Where can we be saving lives for things that we need to put in place that will also help us for a pandemic?
Let me just ask a follow-up question on that. You said that we're making progress in some areas and falling behind in others. Can you briefly give us a couple of specifics in each category?
Yes, I think in areas where I think we're the best that we've ever been is we've significantly improved our communication capabilities. You know, our ability to communicate with the Centers of Disease Control, the BlackBerries that we are almost slaves to in some ways now, but the ability to communicate rapidly. You know, I can have a situation where I can get notice that I need to send something out to 1,500 physicians in my community and to all the emergency rooms, and that can be over the weekend, and I can call a staff member and they can send that out from home, and we can get it into every emergency room with a warning flashing at a computer there. We can get it to the physicians' offices. So many of our communication systems have improved dramatically and are the best they've ever been. I also believe that we have connected in ways with various other resources in our communities and our emergency operations centers much more effectively than we've ever done before. Our lab capabilities are much stronger than they've been before. We still have some places that we can improve those, but we've made leaps and strides in our lab capabilities. And probably, though, the most important thing that's improved is our public awareness that we aren't where we need to be. And I think that is an opportunity that people are realizing that we still need to make some improvements. On the negative side, in many areas, because of local and state tight budgets, I believe we have less disease detectives, less epidemiologists, less people that can do contact tracing and follow up on outbreaks now than we had a few years ago. And it's a little bit like the airport walkway scenario that we may have gotten some additional federal dollars for some of those positions, but we've been losing ground because of tight budgets at the local level. So the actual capacity to manage and do contact tracing in some of our communities is not going where it should be going. Certainly our vaccine production capability has gone the wrong direction, and we really need to go back where we were decades ago, where you've probably heard the term of community policing, that police departments have found that in many cases they need to be out in the community and identified in the community to have trust and to be able to make a difference on issues. Well, that's where public health was years ago, and we need to reinvest in our public health system. So some of you have heard me say this before, that I think we need double Centers of Disease Control's budget, and we need to double the dollars going down to local health departments for every program, because not only can that improve whatever that program is targeted at, but we can be cross-training and making sure that we've got the people on the street in the communities to improve our health so that we're not 25th in the world in life expectancy.
Thank you, Dr. Osterholm.
Yeah, if I could respond, I think, to your thoughtful question. One of the things that we have a problem with today is we live in a world of 24-hour news cycles. And we live in a world, in this country at least, of very different politics. It's much more the politics of bloodletting often than it is the politics of compromise. And that is an unfortunate reality we live in. So anything we try to do is based on that issue. Let me just give you an example. Following the post-Katrina events, obviously Washington and the country as a whole was aghast at what happened, and they needed somebody to blame. And I'm not suggesting that it wasn't deserved or that there was anything other than a miserable failure with the response to Katrina, but Mike Brown became the focus of a sense of who's qualified to do this work. Over my, and just by way of background, I served 2 Republican governors, 2 Democratic governors, and 1 independent wrestler when I was in Minnesota. And I have served as an advisor to every administration since 1988 in our federal government. And my own family can't tell you my partisan politics. And so I want to make it clear that any comments I make cannot be perceived as partisan. I came after 2001 to assist Secretary Thompson at his request, never having met the man before, on the issue around terrorism. And the only requirement I had is that I would speak my mind at the day that I couldn't, I would leave. And I stayed with him in that group for 2.5 years. One of the most competent, one of the most amazing managers I've ever worked with, one of the people that tried harder to get us ready for pandemic flu than anybody I've known is Stuart Simonson, the Assistant Secretary of Public Health Preparedness. His problem is he happens to be a lawyer, and he happens to be in a senior position, and so this city has painted this man as incapable and incompetent because of the fact, like Mike Brown, he was a lawyer. Well, if you use those criteria, thank God we didn't have President Lincoln around, because he too was a lawyer. And what I find really unfortunate is in this town, we don't often really evaluate issues on the truth. We evaluate issues on perception. And so, and in this case, they're out there now calling for his resignation, yet it was Stuart Simonson that right after 9/11 made HHS keep its eye on the ball on pandemic flu. He's a man who brought in an innumerable number of experts, bipartisan, brought them in, they're there, and has run one of the best shops anywhere in this town. And because people don't get it and they're out attacking him, and some of you all in the media just as recently as yesterday were doing that without knowing what you were talking about. That's what I worry is the backdrop for our response to infectious diseases, is we don't often get to talk about the real issues. We have to talk about what is the perception or what is the political point of view at the time. You know, I had the unfortunate and yet, I guess, interesting experience. I was on Nightline a couple of weeks ago, right after the Senate had just passed this bill for $3.9 billion for influenza. And Senator Frist and Senator Reid came on, and I was on there with them, and they were self-congratulatory about they're really going to do this. One of them even made the comment about, this will help us get the, bug-to-drug situation in there. And why I thought it was wonderful that they acknowledged this was an important issue. We needed it. I had to, in my Midwestern understanding of the situation, say, but please, senators, understand that amount of money is like trying to fill Lake Superior with a garden hose relative to the size of this problem. And somehow there was this perception that night that this $3 billion was going to do it. And so part of it is we need to have a much more honest discussion. We need to have a much more intellectual discussion. And I find that very hard to do in this town in a 24-hour news cycle. And so I think that's one issue. The final piece I would just say here in response to your question is, let's just be honest also about one thing. Everyone in this room is going to die. We're all going to die. Unless, depending on your religious beliefs, very few people have gotten out of this world alive. Given that, there always will be a top 10 causes of death. If you eliminate the top 10, there will be 10 new ones, and I'm not so sure they're better than the first 10. So what our goal really needs to be is to figure out not just how we want to die, but how we want to live. And to me, I would assume that a long life, relatively free of infirmity, of poverty, of mental distress would be an ideal way to go. And obviously we're on a collision course with our destiny with world population, and that's got to be an issue we've got to confront. But I can say with some certainty of all the diseases that we could eliminate that would affect early death, would affect death at an untimely time of life, that are diseases of poverty, it's infectious diseases. And interestingly enough, they are the ones that in many cases we have the best tools if we committed to doing it, to postpone those. And so I think from a global health standpoint, if you understand infectious diseases, you understand the life of many of the developing countries of this world. So I want to make it clear that every group, a cancer group, a heart disease group, heart disease people are in town this week, could all have their own same meetings about how we're going to eliminate all these diseases. And we can't. Somebody's got to die of something every day. So what we need to do, though, is figure out where we are. And I just would say infectious diseases are the one preventable set of diseases that we really need to focus on as a world, because it will be all about our quality of life.
Yes, please.
Just a few things there. I will address at least from the global perspective. It's a question of containment at source, or if you like, at various sources, depending on how fast this comes on and how widespread it is. And for this, it's essential to appreciate the need for effective international collaboration. Currently, there are ongoing discussions, including the World Health Organization. Most of you probably know David Nabarro, who is heading up this effort there, and also the World Organization for Animal Health. So this is an issue that cuts across many sectors globally. And in addition to that, it's a question of timing. Well, if it hits today, for example, then all bets are off. Even if one identified the particular strain of the virus today, you need a long lead time to produce vaccines and get them out, and during that period, you may already have witnessed societal collapse. But if it hits in 2 years, then that's a different story. That's dependent in part on how effectively we utilize the next 2 years to prepare for that scenario. So this is a question of playing out different scenarios and, again, appreciating that we live in an interconnected world, and what happens in one place is almost certainly going to affect another. Just switching gears a little, again, taking an international view of this, the potential for avian influenza pandemic is certainly awful. That's beyond debate. But at the same time, it's also the case that non-communicable diseases are actually very serious problems in middle-income countries and low-income countries. There are vast inequalities in the access that people have to information that will help them to preserve their health. People are still exposed to very aggressive marketing from tobacco companies. If you prevent them from marketing it in the United States, they're busy going around in China and poor countries and marketing it and saying this is the good life. Okay? So we still have people who don't have access to information, or if they have access to information, they do not have the means, or they do not have access to health services that screen them so that early detection can be put in place, and so primary prevention fails, you can at least go on to secondary prevention. So while these are very dramatic, the communicable diseases are very dramatic and more dramatic than avian influenza, the non-communicable diseases are still there, and they are biggies in much of the world. Thanks.
Thank you. We had a question here and then here. Let me ask if we can identify ourselves as we speak. I know that the one question from that table was from Phil Musgrove at Health Affairs, but you've got the mic, so please.
Todd Zwillick, Todd Zwillick with WebMD and UPI. Dr. Osterholm, you've talked today and you've talked before about a lack of preparedness. How would you describe the preparedness moves that have been made, announced anyway, in the last weeks and months from the administration? The attempt to buy at least some oseltamivir, deal with Sanofi Pasteur to produce H5N1 vaccine, We haven't seen the HHS plan yet. It's coming soon. But in terms of what has been done and what's been announced in this recent flurry of activity and attention from the White House and the administration and the Congress, how would you characterize its effectiveness or how far it's going to go?
Yeah. Well, I think first of all, one has to add perspective. There's that old concept: you creep, you walk, you run. And I feel like we're getting up on our knees right now, and that's a good sign because it means we're moving. I think that the issues around the HHS plan, which will be released soon, has to be first of all put into context of an international plan and a plan even for our own government that's far beyond that of HHS. I mentioned earlier about transportation. I honestly believe, as I noted in my foreign affairs piece that was in the July-August issue, that we will see, like SARS, which was in a relative sense a minor hit in public health. SARS was not a big public health crisis per se. If you were in areas of Asia, if you were in Toronto, it was a huge crisis. But when you looked at the potential for it to become a much larger international crisis, many of us never felt that was the case. Influenza will be, and I think the transportation issues we saw isolated in SARS will be global in nature. And so the idea of getting food, even maintaining water supplies, I can go through a whole laundry list of things that are well beyond that of HHS are going to be needed. And that's going to have to be done in every country around the world. So I just want to caveat here that the HHS plan should never be seen as the plan. It's one piece of what has to be a global and a domestic plan to be able to respond. I think that, again, HHS has made valid attempts. There have been many efforts made by HHS that were missed. Again, it's not to pick on the media today, but when Secretary Thompson resigned almost a year ago, at his press conference he made two very provocative statements. One was what kept him up at night and what really scared him was flu, influenza, and our lack of preparedness for it. The second thing was he said he couldn't understand why they hadn't attacked the food supply yet. And the media focused 100% on the food supply comment, and the other one was a throwaway comment that never got followed up on by anybody. If you go back and look at the testimony, if you look at the plans that have been put forward, this is coming out of there for a long time. I think what's happening in everyone is to blame for this. There's no one bad person, whether it's the Hill, whether it's the administration in the White House, whether it's the media, whether it's the medical community. Where's the AMA on this issue? I mean, I could go through a laundry list of groups and organizations and establishments and people who haven't been there. And so, we got to let that go. We're here now. We finally are here. The blame game is not going to serve any of us. We all understand we have a major challenge in front of us and we have to pursue it. Now, what does that mean to pursue it? One of the other problems we have today is this technology fix, this idea of the silver bullet. I believe that antiviral drugs really represent a potential tool, a limited tool, but it's not a silver bullet for two reasons. One is we don't know if Tamiflu will work against this situation. Tamiflu or any of the neuraminidase inhibitors, which Relenza is the other one, are exceedingly good drugs for standard influenza, H3N2. We know that if you take them within 24 to 36 hours after the onset of the influenza, you can markedly decrease complications, you can reduce the time you're ill, and we know if you take it before you get infected, you can actually prevent the infection. But this infection, it was asked earlier, is different. H5N1, like H1N1, creates a virus storm early in its infection. It basically replicates to levels of virus not ever seen before in influenza. It infects many more cell types. Remember, we've talked about brain infections, GI infection, other organ infections, which we don't traditionally see with influenza. And what we now recognize is that's what causes this cytokine storm, cytokines being this general chemical release from cells that turns on the immune system. And one of the hypotheses which we believe has actually happened in 1918, why did 20 to 40-year-olds die at the highest rate in 1918? Because the immune system turns on itself. And who has the healthiest immune systems in our population? Well, you spend the first 20 years of your life building up your immune system, and for a couple of you in the room that are over the age of 40, I hate to tell you, but it starts to wane as you get older. And so in a sense, that helped explain this big bolus here. It's this cytokine storm that results from this very high virus production in the very earliest hours of infection. Well, in our lab animals right now, in studies that are being conducted, one was published a month and a half ago in the Journal of Infectious Diseases, if you don't have Tamiflu on board already, if you're not already taking it when you're challenged, and then you have to take it for a much longer time period, a much higher dose, those animals die. And I've not seen anybody in the media do really an exhaustive review of just what does this all mean. Is Tamiflu really a silver bullet? Or is it, in fact, something that maybe if you're not taking it as prophylaxis, i.e. before you're infected, what is going to be the efficacy of that drug? And frankly, we just don't know because we don't have enough data from the 120-some cases that we've seen in Southeast Asia. But yet it's being sold right now as almost the Cipro of post-9/11. The second piece of it is let's just be intellectually honest here. Roche, and this is true for vaccines in general, the best guesstimates we have, because the company won't release the actual production capacity that they're trying to scale up, but at the best guesstimate we have is in 5 years we might be able to make enough of the drug for a one-time production or for one-time protection, meaning just you can't take it every day, you can only take it when you get sick, to protect up to 5% of the world. That's it. So when you think about this as a global issue, a global tool, it hardly represents, a big hammer. And on top of that, I just mentioned, none of you have challenged. We talk about Great Britain is very proud of the fact they have 40 million doses. What does that mean? One, first of all, they don't have delivery for several years yet. Second of all is the fact a dose is based on the H3N2 model. But if you have to take it twice as long at 3 to 4 times the level, that means that's an 8-fold increase of drug you're taking, which means that you have to divide that number that you have supposedly protective doses by 8, or whatever that number will be. So I think there's still a million questions to be answered yet about the role of the drugs in preparedness. And I advocate stockpiling them. Don't get me wrong. We have to do everything we can because we don't know the answer. So it's not as if I'm saying don't do it, but also be careful. Just don't assume, as the public is assuming now, the only way I'm going to get through this is if I have my Tamiflu.
Question there. I'll get to you. And identify yourself, please.
Thomas Nordegren, Swedish Broadcasting. I wanted to elaborate a little about the concept of quarantine. Is it really realistic to isolate a city or even a part of a city? And what is the most rational thing to do medically? And what is sort of, in a worst-case scenario, really possible to make, considering what's happened with Katrina and all this mandatory evacuation that people don't seem to care about?
It almost sounds like you partially know the answer to your question.
No, I don't.
A large city has too many points of entry and exit. And if people are being held without their understanding of why, all of our laws are primarily self-policed or self-enforced. And if people don't understand the reason for them, aren't prepared for them, and aren't following them, it's very difficult to enforce them for the masses. You can take a few people that choose not to follow something, but it's very difficult to do it for everybody. Now, if you're talking about a very isolated small area where this might break out first, you might get lucky. I don't have a lot of confidence in that. What I think is more important, and it's the same thing with our experience with SARS, the issue is it's kind of like a nuclear or a chain reaction. You've got things happening and spreading, and if the rate of spread is slower than 1-to-1, then it goes away. If it's faster than 1-to-1, if more than one person gets it from every person on average, then it expands. And so we need to be doing everything that we can within reason that will help slow that down. So the hand washing, the various kinds of voluntary restrictions in activities and meetings, they can and probably would make some difference. But just to give you a sense of the scale, when we had SARS in Toronto, not that communicable, but we had as many as 7,000 people on recommended quarantine, isolation kinds of situations where there needed to be somebody checking in with them to find out, are they still honoring that? Because most will. But the staffing at that local level to do that phone checking up and then going out if you have a suspicion that the person may not be there, that takes a lot of people at the local level to manage that kind of an event. And that's what I was saying we don't have in place right now. Because you're not going to have the silver bullet, I don't believe. You're not going to have something that's going to magically cure this. It's going to be all the tried and true ways that we slowed down epidemics before there was penicillin.
Could I just add on the quarantine piece that, first of all, the term quarantine and isolation get confused often. Quarantine, which actually comes from the Latin 40 days, goes back to the earliest days of the ports in Italy, where they knew that ships coming in, if they held the ships out at bay for 40 days, that if plague was on board, the sailors would have gotten sick by then, meaning rats with fleas infected with the plague bacteria. And so they kept them out, and then they let them come in if everyone was well at 40 days. That concept has obviously gone through some evolution since then. But quarantine today still means we've identified a group of well people who were exposed to an agent that could come down with it. A good example, if I had influenza this morning and was in this room, you all would be seen as potentially people who could be quarantined, because now over the next 3 to 5 days you would likely come down with influenza. And it means a very different thing today for those diseases where we do it. Smallpox would be one where we could still do it. SARS was in the healthcare setting something we could do. What determines that? It's how infectious you are and what are the consequences of doing that. And today most quarantine, if it were to be done, is voluntary, in the sense of just saying, now you know you've been exposed, please don't go out, minimize your contact with others. If you get sick, call. I will just say at the outset here, I can't imagine under almost any circumstances quarantine being useful or effective with influenza. And I say that because of the infectiousness of this agent. It will spread. There is no evidence quarantine makes a difference. If we're in the earliest days of the situation, and let's say we have a 747 coming in from Asia, and we have somebody very ill on board who came from that area where we know it's just emerging right now, and we have no illness here, I could see theoretically taking the passengers and the flight crew of that plane and trying to put them aside, ask them if they would self-contain themselves for 3 to 5 days to find out if they get sick. Beyond that, I can't imagine anything. The term isolation means I'm already infected now. And now how do I keep me from transmitting to others? And in that case, that's a very different scenario, because now what it's asking me to do is not to try to expose myself to others, or more importantly, isolation often means in a hospital setting making sure I don't transmit to someone else, or whatever setting it is, by infection control procedures. So I don't know if that gets back to the answer, but I don't see a role for quarantine in influenza.
We had a question over there. You want to do the mic?
I can shout. Robert Boyd from McGinners. I understand that HHS is developing in the lab a vaccine which is apparently quite effective against the bird versions of H5N1. But is it the case that if that H5N1 mutates so that it can be easily passed from person to person, you need to go back to redesign the vaccine and start the whole process over again? How long that take?
Actually, the vaccine you're referring to is one that was reported, the initial results in the New York Times about 2 months ago. Those studies actually were done using isolates from humans that were obtained almost 2 years ago. In that situation, what was done was something that, again, technologically we had no reason to believe couldn't be done. Could you make a vaccine against that strain, that particular strain, and challenge in both laboratory studies and potentially animals the protection from that vaccine using the same technology we're using today? 2 things were learned. One, yes, you can, and which we thought. But 2 was the question that we all had, is how much antigen or virus would it take? Remember when we grow up a chicken egg, we intentionally infect it with the vaccine strain. We try to grow it up in that chicken egg, and then we harvest that. And the yield in that chicken egg gives you the amount of antigen or the amount of material you can use to make the vaccine, and that's our limiting factor. In this case, the studies showed that you needed 2 doses of vaccine, and you needed 6 times as much in each dose, i.e. 12 times as much antigen as the current vaccine that we have out there to get protection. Now, I don't believe that'll stay the same. I think we're going to reduce that with some better techniques. But the bottom line is that what happens is this vaccine is going to take a lot more antigen. So again, on a worldwide basis right now, we have enough vaccine capacity around the world in a year's time to make it about 1 billion doses of influenza vaccine using our current levels, 15 micrograms of antigen. If you suddenly need 12 times that much, that means in a year's time, you may be talking about our ability worldwide to make only 85 to 100 million protection doses, i.e. protect people, because remember it's 2 doses. That means in a whole year's time, 85 to 100 million people may have access to the vaccine out of 6.5 billion. So again, the good news is we can make a vaccine. The bad news is, so what, in a sense of stopping a pandemic of influenza? Well, if you're one of those 88 to 100 million, that's a big so what. It's a great one. But it's not going to affect the impact of the pandemic. To address your question about will the vaccine work, today you're going to need 2 doses. If you could use this to prime, in other words, the first dose, that would likely yield some real protection. It wouldn't be ideal. It wouldn't necessarily even be great. But it would, truly leave a number of people much more immune to this virus than not. And so the thought is what vaccine we do have could be used as a first dose, and then we would need, of course, the circulating strain of the virus, particularly if there was a recombination or a reassortment as opposed to a recombination, which now means it's really a different virus, and that's the research. So I think it's a great piece of research. It's important, but again, it's that relative issue. What role will vaccine play in a 12-month period of a pandemic when you realize how much we can make? There just aren't any more pipes. There aren't any more machines. There aren't any more buildings to do that right now, and to make that's going to be a real investment to change that. I liken it to, if 10 years ago, again, I mentioned earlier, if somebody had gone to Boston and said, we want to do the dig in a weekend, we don't want to tear up the city that long. And everybody could have said, well, how much is it going to cost? It wouldn't have been about the money. It was about the ability. And that's where we're at with vaccine today. We need to invest the money for the future, but it ain't going to pay off in the next 12 to 18 months.
Let me ask you to hold your question for just a moment. This has been a great discussion. We have focused on avian flu. Our next panel is going to look at a number of broader issues, but that are going to integrate, basically through comments from you and our speakers, avian flu in a larger context. I'm going to suggest we take a very brief break. There's coffee and juice and other stuff in the back. We will come back here in about 10 minutes and continue. I congratulate you on your questions. This has been a terrific discussion, and for the speakers, a genuine public service. Thank you.